And thanks to my colleague. Thanks to my, yes, are you all happy for us to record the meeting? If anyone is against, please let us know. As I was saying, ERCA represents some 16 European rural organizations, some within the European Union and some outside, which is a challenge in itself, but also a privilege and an opportunity. And in trying to make sure that our members get value for money and good service, my colleague Ben here and Louise, Vanessa, who is our coordinator, but I think is not able to join us today unless he joins later on. And Wendy quite rightly proposed that we should provide, first of all, briefings for our members, that we should get feedback from our members, and that we should invite individual member organizations to present a view of their geographical representational area, but also any theme that they wish to have. So this is part of that dialogue, which I think is extremely useful. When I saw the title for today, my first reaction was, great, my wife can come, because my wife's been a medical doctor in a rural practice for 35 years. And my daughter is also in medicine, but because it's half term, they are both occupied with either grandparenting or parenting duties. My wife also used to belong to a rural research center, which some of our speakers today might have been aware of. It doesn't exist anymore. It was called the Mid Wales Research Rural Research Centre, based at a university property called Greganog, and led by Dr. John Wynne Jones. And he did quite a lot of innovative work using technology and so on as it emerged back in the 1990s. But as I say, that doesn't exist anymore. The topic of rural health, one of the issues that's a bit of a Cinderella always in European policy discussions is that because it's a matter for member states as opposed to the Commission directly, it tends to get sort of rather downplayed, and the same applies to obviously formal education. But it's obvious, anybody who wants to talk about the quality of life and the attractiveness of rural areas to young people knows that health standards and health access to health services is a very, very important topic. So it's great today that this is being discussed, and I hope we have a good session. I'm going to hand over now to Ben, the Vice President of ERCA, to introduce the speakers. So over to you, Ben.
Thanks very much, Tom. Just a few words on the logistics. We will have 3 speakers to lead us through the team. Kate Clifford and Ivan Annibal will introduce the issues, and then later on, Karen Kay will kind of put a European perspective on this. That would be about, and then we will go out in a breakout room. So every one of you will have the possibility to also share his own experiences and discuss a little bit the possibilities and perhaps the good practices in his own regions. I think that would be our program, and then later on about 10 before 1 o'clock we will wrap up and close down. Louise, we have a recording, so later on we will publish kind of a report on this web event, and you can come back to that if necessary with questions also, because that's what these web events are about, sharing knowledge. And we are very happy that our Northern Ireland member Rural Community Network in the person of Kate offered to bring us a web event on rural health needs in Northern Ireland and on rural health in healthcare in rural communities. So we are very happy that Kate will introduce her experiences in Northern Ireland together with Ivan, and Ivan is from the National Centre of Rural Healthcare, Health and Care in in the UK, and he will share, and I'm very curious about his example of this rural toolkit, because I think that the theme for today is also, and you have read the introduction, is what can rural communities do themselves to rescue all these healthcare issues. So, Kate, up to you, and we will be happy to hear your story from Northern Ireland.
Good morning, everybody. Thank you so much, Ben, for that introduction, and Tom as well, and Louise for setting all of this up. I'm going to screen share now, folks, and get straight into this. So what I want to do is paint a context of the issues in rural Northern Ireland. Then I'm going to introduce Ivan, who will talk you through why they came up with the toolkit that they came up with. And then I'm going to give you an example of how we've used that toolkit in our only island community, which is the most rural location in Northern Ireland. So if my screen will share now. Sorry, just 2 seconds, folks, when I get this up. Okay, so here are we. Are the slides moving?
At the moment, we're seeing your sort of overall overview with 2 or 3 slides and then a smaller inset first slide, Kate.
Yeah, it's not. I'm going to stop sharing and come back up again. Sorry, folks. This is your worst nightmare. It's not moving. I don't know why it's not moving, folks.
You might just be able to move through these.
Yeah, now it moves. Now it moves.
Yeah.
Okay. All right. Try from the current slide. No.
I think you might just have to move it like that, Kate. You can move through it like that. If you click on the next slide down, I think.
Yeah, let's just do it this way then. Sorry, apologies, folks. So in terms of the Rural Community Network, we're a membership-based organisation supporting rural communities and groups that are working on a community and voluntary sector basis across Northern Ireland. And a big part of our job is around building capacity and voice for communities to influence policy. And our focus is on, sorry. So our focus is on poverty, inequality and community development. Just for those of you who live outside of the UK, it's just to show you where we're at in terms of the map. So we are a small rural region, at the edge of Europe. Now we have Brexited. We're the only part of the UK that shares a border, a land border with a European community. So we share a land border with the Republic of Ireland, and we're a very rural region. So just to give you an idea of our rurality, 37% of our population live in rural areas. Anything that's white on the map is outside of a 30-minute drive time from settlements of a population of 10,000 or more. Anything that's in red is populations of 5,000 or more. And so that just gives you an idea of, like, the red bits are the white bits are the bits which are mostly rural. There's an exception in the middle there, which is Lough Neagh, which is the large white blob right in the centre. But around the edges, you'll see just how rural it is. We have one inhabited island, which is marked there with an arrow at the top, which is Rathlin Island, and we're going to focus on that later on. We have policies on health, transport, housing, which all affect, disproportionately, I suppose, affect rural communities across Northern Ireland. Because of rurality, because of distance from services, because of lack of access to transport. And my next slide just gives you an idea of the regional imbalance across Northern Ireland. So your blue lines on that are our railway lines. That's the railway line that exists from Derry City up in the northwest, down as far as Newry, which is down at the very bottom of the map, beside where the quay is, largely connected in and around Belfast. But the rest of Northern Ireland is not served even by a railway. Our yellow is our motorway, so you can see how much of Northern Ireland is connected by good roads. And the rest of it is all sitting with B roads and minor roads as opposed to good quality roads. We've a mixture of really well-connected rural areas, and then we have an awful lot of isolated and then border communities which have very poor connectivity into the administrative centre, which would be Belfast. Access to health provision is equally badly balanced. And just to give you an idea of a comparison along those, if you look at where our hospitals, anything in yellow is what's termed in Northern Ireland as a golden hospital. So they are hospitals that have a full complement of services, including cancer services, maternity services, and A&E with general surgery attached to it. Anything that's highlighted in pink or pinky colour there as a dot, the Southwest Acute, Daisy Hill Hospital and Causeway Hospital are what we call silver hospitals. They have almost all functionality, but not everything, and some specialisms. So if you went at the moment to Southwest Acute Hospital, you could have your baby, but you could not have emergency general surgery. And our issues at the moment are that if you do the comparison map there, the lack of connectivity and the lack of access to the golden hospitals, it's like one is directly inverse proportion to the other. I suppose that the more rural you are, the more remote you are, the less access you have by good roads or rail links or public transport to those centres where emergency care is provided. And that becomes a real challenge for our communities, and particularly that area in the kind of browny colour at the edge, which is the Western Trust. Our organisation is based just where you see the Mid-Ulster Hospital, Magherafelt Health Centre, right in the centre. They're kind of downgraded hospitals, which are big, like county or community hospitals. They provide outpatient services, and they might have an accident and emergency and X-ray facility 9 to 5, Monday to Friday, but don't work weekends. So, you have to time your heart attack and time your emergency to be between 9 and 5, Monday to Friday. So it's a really difficult challenge for those people who live in the western part of the province and along the border regions to have equity of access to health service. And I mean, the common phrase around many of our rural communities is just don't get sick, just don't become unwell, don't have an accident. The healthcare challenges for Northern Ireland, just to give you a really quick overview of this, is that we have a system that is under severe workforce pressure. This is not unique to Northern Ireland, it's happening right across the UK. But we have the highest number of vacancies across the HSE. Their largest shortfalls are in social care and nursing. We have tens of thousands of people waiting for elective care and long outpatient waits with red flag lists. That's people who have been red flagged are emergency people who should be seen within a 2-week window are now averaging about a 12-week wait. And urgent care has a 56-week waiting list and more. Some people are waiting up to 3 years for knee or hip operations at present. Our GP coverage is shrinking. We have fewer practices, so as our older GPs retire, they are not being replaced in the system. We have fewer practices and we have rising patient lists. Multiple GP practices have handed back their contracts with the health service and have said that they no longer are prepared to work in the conditions they think it's unsafe. That has happened more, and it's happened in urban areas. It's not to say that it hasn't, but it is happening more and more in rural areas. And lots of our GP practices are saying that they're working unsustainable hours. They're really having difficulty finding locums. and partner posts are just impossible to fill at present. So our big thing is as well that there is no workforce planning for future-proofing our GP services across Northern Ireland. One statistic that was quoted to me recently by a doctor was that there were 73 GP practices in 1956 in the rural northwest, and that there are now only 53 practices covering the whole western region, so that whole brown region on the map that you see above. Just in terms of key statistics, just to give an idea of the challenge we have, is there are 305 active GP practices in Northern Ireland, and the average number of patients per practice is 6,777. That's up 23% since 2014. That's a 23% increase in the number of patients GPs are expected to see. And if you think about it, every contact in the health service generally comes through your general practitioner. So all your referrals, all your first point of contact is your GP. The HSC vacancies are around 5,000 at present, and that's a variance rate of about 6.4% of constant vacancies. We have over 545,000 people waiting for elective care surgery, and that's outpatient and inpatient. We have patients working for a consultant-led appointment. The first one is around 61 weeks, which is nearly a year and a half. And we have 952 professionals have left the register in the last 12 months. And that's an exit from the service. So the system is collapsing from workload and work pressures. But at the end of this, individuals are suffering most. And those who are furthest from the healthcare centres are the ones who are likely to be most neglected in all of this. To paint an even darker picture and to be really doom and gloom about it, I'm going to mention the border and Brexit. So there have been massive problems in terms of workforce recruitment in Northern Ireland, largely because of the pre-settled status or settled status now. So the right to work in the UK has changed slightly. We were very lucky in that we're a little bit protected in Northern Ireland with a common travel area, which predated our existence into the EU. But challenges for us are around Brexit has made recruitment and retention for some migrant workers much harder and much more difficult. It has created an extra barrier and real challenges. And then on the other side of that, having shared a land border with our European counterparts in the Republic of Ireland, they have really done an awful lot of work around their active recruitment and clearer registration. And a lot of people who are living and working in Northern Ireland as healthcare professionals have opted to travel to the Republic of Ireland to now be registered and working there. And that has caused another onslaught, I suppose, particularly in rural regions where access across the border is easy. So a lot of people who are based in that Southwest Acute Hospital are now working in Letterkenny and Sligo. So it's a little bit longer of a commute, but working conditions are better, registration is faster, and career progression is much better as well in a much more organised system. So just to give you a really quick overview, primary care, we have GP shortages, fewer practices, rising list sizes, less capacity for routine work, less capacity for intervention and prevention work and upstream working. We have started to roll out a thing called multidisciplinary teams. So people aren't just coming in to see their doctor, but they can see an OT, they could see somebody who was doing physiotherapy. If it's a constant back problem they're not coming into their GP just for pills, but we're trying to do a multidisciplinary team with some of the practices. It has worked really well in urban centres, much more difficult to step up in rural areas where there isn't the site capacity for the health centre to be developed, and it has taken time to develop multidisciplinary teams in where GP practices are mainly based in the high street and have no room for expansion. So there are logistical challenges around some of this too. In secondary care, we're just seeing an overwhelm in ED. All of our access to hospital happens through the ED. So any referral from a GP is immediately through A&E. It doesn't happen directly, and there's consultant-led applications as well. But if you're sent from your doctor for blood tests, you go directly through ED, which then is causing huge pressures in the emergency departments that we have. And then we have massive, massive issues around social care. So our vacancy numbers are among the highest in any HSC wide in the UK. we have capacity constraints in domiciliary care, and delays in release from hospital are then causing a backlog in hospital, which is causing bed blockages, but we can't get packages stepped up in, particularly in rural and isolated communities, for people to have the right necessary social safe care that they need when they're released from hospital. So where do we fit in? The community and voluntary sector in Northern Ireland is plugging gaps in. It's a little bit like as the dam bursts, we're plugging all of the gaps in the holes. We can't stop the water coming through, but the community and voluntary sector is really stepping in to provide voluntary care in the community, support networks, community transport, luncheon clubs, social care, health and crisis intervention and mental health. So there's loads and loads of stuff happening, but the sector's not being funded either. So just wanted to go into that really quickly before I hand over to Ivan. Community-based services are preventing unnecessary hospital visits, offering home care, intermediate care, and support for discharge planning. A lot of our work is supporting independent living, supporting people to stay in their own homes and live independently longer through community transport schemes, luncheon clubs, maintaining people's mental health and maintaining people's social contact. So we have a lot of social prescribing happening here in Northern Ireland as well. Voluntary organisations are increasingly involved in delivering mental health support. And for a long time, we were around mental health early intervention. We're now at crisis intervention. So we have suicide intervention happening from many of our voluntary groups. I've mentioned community transport. There's early intervention for children as well. Paediatric services are playing a vital role in early diagnosis for developmental conditions. Autism and autism spectrum disorders are more widely recognised than they ever have been. And we now have loads and loads of groups that have been set up by parents who have become experts by experience, who have set up early intervention and support networks for people right across Northern Ireland. Difficulty for us is that lots and lots of the children who are on waiting lists for statements to get support in school are waiting 3 and 4 years for that intervention, which is far too late by the time a child's gone through primary school to get that support. And that then creates longer term problems within systems if kids are not supported and enabled to manage their conditions and understand their conditions as they're going through primary school, and they're not given that intervention and that support as they go along, and nor are their parents. We have lots and lots of localised and integrated care systems. There's a real recognition of the heavy lifting that the community and voluntary sector are doing, but our difficulty is, and the challenge is, that funding and resources are, we are in a huge deficit here in Northern Ireland from the Exchequer. And just to give an example of how stressed the system is, that the core funding grants for people who deliver health and support within the community and voluntary sector in Northern Ireland, 260 organisations applied in 2025. Only 25 received funding. The cut came to the overall budget by 50%. And that meant that lots and lots of groups who were core funded, providing vital services in their communities right across urban and rural, ended up not being refunded. Coupled then with the exit from Europe and the massive intervention and support that came from particularly the Rural Development Programme for rural health care and support, that then has undermined the capacity of the sector to continue to meet the health needs in community-based care. In all of this, we are still looking at solutions and we're looking at what can be done. So I just put this slide up because I want to introduce the Rural Needs Toolkit, which was something we came across through our work with Ivan and Jessica. And we know from community development and community-led local development that when we understand the assets and needs of rural area, when we understand and see demonstrations from other areas around Europe and around the world at what works, then we can set up working in partnership across communities and cross sectors to make improvements to achieve better outcomes. Rural areas are not homogenous. Very often local solutions are tailored to meet local needs. And we know when that happens, when we have discussions and we understand those needs, we can come up with long-lasting, long-term interventions which have the correct impact. So I'm going to pass over to Ivan, who's on the call today with Jessica from the National Centre for Rural Health and Care.
Thank you, Kate. So I'm just going to talk for a few minutes about the origins of the Rural Needs Toolkit in a Northern Irish context, explain where it came from, and just look at some of the sort of solutions that we've tried to help develop to address some of the sort of quite grim sounding issues that Kate has run you through. And they're not unique just to Northern Ireland. A lot of these issues exist across the whole of the UK and I suspect other parts of Europe. It's worth just giving a shout out to John Wynne Jones that Tom mentioned at the very start of the call, because he's on our board, and some of the learning that he's brought from his experiences in Wales has informed the whole journey that I'm going to talk about. So if we can go to the next slide, please, Kate. So the National Centre for Rural Health and Care was formed in 2017, and it has a HQ which Jessica and I are based in Lincolnshire, which is one of the most rural parts of England, which is not very rural in some European terms, because England's a very small, densely populated country, but nonetheless it has a more rural context than most of England. And the National Centre for Rural Health and Care operates across the whole of England, and also has key footprints in Wales and Scotland. And it really exists to try and think about two things. One, how can we make the different components of the health system able to work better together in the interests of rural communities? And secondly, how can we build the capacity of rural communities to be more resilient without necessarily needing to access direct rural services? And through a lot of research that we've done, we see this in the context of four key themes that are at the heart of our mission. The first is to actually look in detail at what the data tells us, so that we've got a clear understanding of the distinctive issues in rural areas, because a lot of the time national data does not think in any great depth about rural contexts, because rural dwellers tend to be a smaller proportion of the overall population, and issues get missed. The second thing is that there's a huge amount of research on rural issues, but it's not collated in any given place. It's very hard to find a cohesive listing of key good practice. So we've done a lot of work to begin to pull that all into one sensible environment. The third thing that we're really interested in is technology and its ability, not as an end in itself, but as a means to shrink distances and to enhance the experience of rural dwellers by actually bringing services to them rather than expecting them to go to services. And then the fourth and the biggest and most challenging aspect of this whole agenda, which both speakers have alluded to so far, is the workforce agenda. And rural settings find it very difficult to recruit people with key clinical experience for a whole range of reasons. So it's against the background of those issues that we developed as one of our outputs an English-based toolkit to look at how one could address what we might describe as rural health inequalities, some of the issues that Kate talked about. And that was very popular and very successful in England. And because we've a very good long-term relationship with Rural Community Network in Northern Ireland, we suggested to them and a number of the health boards in Northern Ireland that there would be some merit in repeating the exercise of developing that toolkit in the context of Northern Ireland as a specific place. So if we could go on to the next slide, please, Kate. I won't dwell on this slide for any length of time because Kate's really talked the key issues through around the rural context of Northern Ireland. But one of the big issues that exists in Northern Ireland that is distinctive from the rest of the UK, but which has a real impact on rural health and care, is relative poverty. And in most of rural England, you will tend to find that rural areas are per head more wealthy than urban areas, because people that do quite well in the city like to retire or to move to rural settings. In Northern Ireland, it's different, and you've got this particular combination of rural poverty, a higher proportion of people living in poverty in rural communities, and ill health. And when those two things come together, it's a particularly bad combination of things which are mutually and negatively reinforcing. So that's just one example of why we didn't want to just go down the route of changing the title and the logo on the England toolkit and saying, there you go, why don't we actually follow these solutions in Northern Ireland? Because as Kate said, and there's a great thinker in global terms about rural settings called Professor Roger Strasser. Rural areas are not homogenous, and he always says when you've seen one rural place, you've only seen one rural place. So the distinctive nature and difference of rural settings is very important, and the Northern Ireland Rural Toolkit has a range of very distinctive things which are pertinent to Northern Ireland, and we assembled it through doing detailed research on the ground about the context of health in Northern Ireland, and then pulling together a particular approach to how people might tackle some of the issues. So if we could have the next slide, please, Kate. Arising from that research, we came up with 8 principles that we thought were really important in addressing the challenges people faced in rural settings in Northern Ireland that underpin what we suggest different players do in the context of the toolkit. Some of these issues, I know from work we've done on a global basis, are pertinent probably to everybody on this call. So these principles were first of all, that where services needed to be located in an acute or a secondary hospital setting, work should always be done to think about how they could be made as accessible as possible to people who live in rural areas. And that could be about community transport, it could be about the use of technology, but that's a really important first principle. The second principle is that non-acute services, what we call primary services, we think there is real merit in doing more work to think about how they can be made accessible within localities, particularly for people who might have problems with low income or travel difficulties. The third thing is that we believe, and there's lots of good work, for example, the Netherlands is an area of very good practice in this, that the more you can help people live at home independently, the better quality of life they have and the less pressure they put on the public purse. So the third principle is that we think it's really important to think about how we can support people to continue to have a good quality of life in their own homes, and the longer they can stay independent, the better. The fourth principle that's very important is that we tend to split health and care. And we tend to have different systems, particularly in the UK, that fund health and then adult social care. And we think because they are so closely linked, policy design needs to think really carefully about the relationship between those two factors, and to look at how joined working around initiatives such as multidisciplinary teams that Kate mentioned can work. The fifth point is that we think preventive initiatives are really important. So things that actually think from a rural perspective about how you overcome challenges to people's health, particularly, for example, mental health linked to things like social isolation, are really important to think through in policy terms. The sixth key principle is around digital adoption, and we believe that wherever possible, it should be utilised to its fullest extent for the benefit of people in rural settings. And we've seen quite significant clinical consultations, for example, being able to be held in people's homes using rural technology, using digital technology in rural settings. The seventh point is around workforce planning, and we believe that workforce planning is crucial if we're going to attract people to want to work in rural settings. We're working actually in England at the moment on a specific set of interventions that we're proposed around building a rural pipeline and a rural workforce, and perhaps we can talk in the breakout sessions or towards the end of the session about that. And then the final point is that we really think it's important that policymakers, when they're looking at the impact that they've had, are able to break it down, not just in terms of different conditions and different communities, but in terms of different localities, different places, so that they can understand the impact of rurality on service outcomes. So if I could have the next slide, please, Kate. So what the toolkit does is it takes those principles and it applies them for each of the different themes on the right-hand side of this slide as you look at it to a planning cycle. And it supports individuals and organisations involved in health moving through this planning cycle of analysing needs, consulting, defining, considering options, adapting proposals, and adapting activities, and then monitoring and reviewing what they've done. And for each of these 6 core areas, acute hospital services, primary and community health services, mental health services, public health, social care, and workforce, we have a separate chapter that works through that cycle. Now, if I can have the final slide, please, Kate. And in each of those chapters, we first of all set the context that explains how that particular theme works at the moment. We set a number of key questions which we ask people delivering services in relation to that theme to think about. We have some case studies of good practice based across Northern Ireland that people can look at when they're thinking about answering those questions. And then we look at some wider solutions which aren't just around Northern Ireland, actually. They're around broader policy things. And then we have some international examples. So there's a really structured approach. And by working through that toolkit and thinking through the issues, people can begin to assemble their own solutions to the key challenges that underpin the agenda. And we've worked really hard, and Kate will talk in a second about the experience of Rathlin Island, to embed this with policymakers so that it provides an aid and a tool for people to make sure that they just don't try and deliver the same service across the whole of a geography without taking account of some of these very distinctive challenges. And we certainly have got experience in England, and Kate will talk about the Northern Ireland experience of how following these principles within a local health ecosystem can actually deliver at sometimes a reduced, not an increased cost, better outcomes for rural dwellers. So that's really the background, and I'll hand back to Kate.
Thanks, Ivan. Thank you so much for that. So what I want to do now is, we have one inhabited island in Northern Ireland, which sits about 10 miles off the northeast coast on the map of Northern Ireland. It's remote, it's rural, it's closer to Scotland than it is to Northern Ireland at parts of that kind of coastal region. So the idea was that Rathlin has a population of 179 permanent residents, and in the summer that population sometimes swells to well over the 250 mark. It is like a little bit like a Disneyland for visitors. People are very interested. It's an easy, accessible boat ride away from the mainland. And because it is kind of a novelty of being the only rural island or the only island community in Northern Ireland, it has become a real focal point for visitors. We've developed a really strong linkage with that island. And so we asked them if it would be okay for us to use the toolkit and test the toolkit on our only island community. The background to this is that there is a permissive document, a policy, which says that things that need to be done differently on Rathlin Island can be done differently by statutory bodies and service delivery agents because it is an island community. And so if it works for the island, that it's deemed to be something that can be put into practice. And that Rathlin policy is a permissive policy. So we thought we're better to test the toolkit and potential solutions than on the island. So the process was that in the idea of identifying the needs, we took an appreciative inquiry approach. So we came from an idea of what's working and what could be better. What it would be better if is kind of the question we asked. We spoke to 46 residents in total. And the findings were what the majority of people were saying in our conversations. But we were also very attuned to the lived experience of people who had a unique experience on the island. So the parent of a child with a disability, parent of a child with a lifelong condition, somebody who was accessing cancer services in a distant or remote area, somebody who was a regular attender with a GP, and people who had suffered mental health crisis as well. And we also went to workforce people. So it wasn't just residents, but it was also people who deliver services on the island, and we spoke to them as well. So Rathlin Development and Community Association were absolutely instrumental in getting us onto the island and allowing us to speak to the full, I suppose, the full generational age range and interest groups that we needed to speak to. So we took the 6 themes that Ivan has already mentioned, and we asked what would help. There is a permanent nursing service 365 days of the year on the island, and 2 nurses rotate 7 days on, 7 days off over the entire year. It's an essential service, and it's very accessible. There's no GP service on the island, and there's no emergency care service on the island. People said that the accessibility of the nurse was great. There was empathy, care, and professionalism, and they provided an important first-line link into GP services in the nearest town, which is in Ballycastle, 10 miles away by sea. But it would be better if prescriptions are not delivered on the island. They come over on the boat and they sit in the shop. Up until COVID happened, they were delivered by nurses. So nurses would have taken the prescriptions off the boat and delivered them out to households. That would have given the nurse an opportunity to check on someone who was unwell, to put their eyeballs on somebody who might not be very vocal about their illness or their difficulty. And it created that additional support and care in the community. When COVID happened, it became uncovered very quickly that nurses should not be delivering medication. It's outside of their contract. And that then became a problem. And there was absolutely no backup to that. Nobody had any clue as to how that would be replaced or how that could be serviced. Then the nurse practitioner role was the next bit. All the nurses can deliver all the nursing care that's required, but they cannot give emergency pain relief. So if someone fell and broke a hip, they couldn't administer morphine, and they can't do stitching. So if someone falls and breaks their skin open and needs stitches, they can't get those on the island from the nurse. So there was a real need to enhance the nursing role to practitioners' role. There was a concern then that health trust and service bureaucracy is hampering the day-to-day working of nurses. So there was limitations that exist on the mainland because there are backup systems in place were limiting what was available to nurses and nursing care, which was needed on the island. Just look, very simple things also came that around care and support for older people was crucial. GP services in Ballycastle, like everywhere, are hard to access. So we now have a system where you must ring at 8:30 a.m. for an appointment that day. But if you have a 10-mile boat ride in inclement weather and you're uncertain about what time you'll land in Ballycastle or what time you'll get back from that, people are then being given an appointment in Ballycastle at 3:40, but the last ferry back is at 4 p.m. So it means an overnight stay. If you get a late appointment with your GP, and even if you're unwell, it could mean an overnight stay on the island or on the mainland for people. And it's just that kind of those difficulties and challenges that are unique to the island setting were uncovered and surfaced in this. I described the use of the toolkit as literally like flooding a cranberry field. We knew the issues were there. We just needed to float them to the surface to be able to talk about them and have the conversations. It's kind of that stuff that everybody was aware of. People were living with it, but didn't know how to find a solution to it. And until we took the toolkit to the island, we didn't get to see the extent of the cranberry field, if you like, if you use that analogy, that once stuff rose to the surface, we were able to then have discussions with the healthcare providers and those who provide services to say, how could we improve this? How could we make it better? I don't want to go through all of the findings. I don't want to take up all the morning, but things that occurred to us around the rurality where people don't get it. They don't, if you've never lived rurally and you've never had a problem accessing transport, or you've never had a problem in getting to getting your prescriptions, then if you've never encountered that, if you're just encountering an urban setting, the not getting rural is part of our rural proofing and the need to articulate the needs of communities. Interagency communication is poor anyway. We work very much in silos between agencies, but on the island it became particularly acute and it could be much better. And again, the other things were around the access to transport, that just things that could be improved. Other parts that were talked about were around the prevention and intervention stuff. There was a need for a community facility. There is no community facility on the island. There are lots of small venues, but there isn't a multifunctional community space that can be utilised all year round. And there was a massive issue around crisis intervention, that if a crisis happened on the island, emergency vehicles are really they're really poor and potentially inadequate. There's no petrol station on the island. There's no place to store diesel on the island. That's a huge issue if you hit an emergency and all your emergency vehicles are requiring diesel, or you need diesel for generators. Other issues that surfaced were around addiction and access to support services. If you're living on an island, you're very visible. Your mental ill health is very visible. And it was about how do we create safe spaces for people to access very personal care and support, which could be very public in an island's community. There was no system for dealing with mental health or crisis episodes. And that's taken account of visitors coming to the island in the summer because they want to find a remote space and they are unwell and they're looking for a place potentially for all sorts of mental health crisis issues. And there was no system on the island to deal with that as it arose, and it has arisen. Isolation and mental health issues and the challenges of winter. And then the other things around, most people on the island are working not one job, not two jobs, but 3 jobs and volunteering in several organisations. So there was this issue around how do we get a better work-life balance and also better quality paid work for people living on the island. Lots and lots of people are kind of supplementing incomes with the tourism season, with emergency services provision. So, they're a fireman and they might be a postman and they might be a fisherman and they might be running a B&B. So people have multiple jobs.
Kate, could we speed up a bit?
No problem at all. I want to go through, it was like primary and healthcare. We asked the questions about what are the needs of people on the island. Primary and community care, mental health services, what could be improved. I don't want to go into all of these in detail, but what we came up with was the impact of all of this. The toolkit has allowed us to begin to have conversations not only with the island community, but also along with service providers. The Rathlin approach is something that has become really, really strongly embedded now in the health service provider from the health trust in that area. They have decided from this toolkit, from the use of the toolkit, to take a place-based approach to healthcare investment on the island. We've begun to talk to nursing leads about the changes that are needed for the nursing contract for those people who are unique to the island. There's been a massive focus on prevention and intervention, that early crisis intervention, the moving upstream stuff around getting health checks and public health messages to the island in a timely fashion. It was largely neglected. It was kind of assumed that somebody was doing it, but nobody was actually doing it. And there's been a real focus on youth and access to sport. And we've gone back to a number of community and voluntary sector providers and the Northern Health and Social Care Trust to talk about how do we support young people to be more resilient on the island when they don't have a sports playing field and there isn't a history of sports teams in the area because they simply just didn't have the numbers for it. I suppose the roundup on this is that there's a lot of work to be done. We've received funding to continue the focus on Rathlin and other areas. We started the process in 2023. It has taken us until now to secure funding to bring the findings of the toolkit into a logistical framework. I feel like we've been doing this at edge of desk without funding and without resource for the last 2 years. We've now secured some funding to finish the work on Rathlin and to encourage roundtable between community and voluntary sector, statutory sector, and those who provide, even in the private sector, some intervention work, and to bring that to the island community in order for them to decide on what way they want to move forward. So if I was to summarise it, the toolkit gave us a way to start a conversation. It gave us a systematic way to uncover issues and a methodology through which we could be solution orientated to undertake an asset-based community development, working with the community and service providers to find a way to improve their lives. So it was a toolkit through which we have developed and supported conversations to happen to find solutions on the island. We are now taking it to rural Fermanagh, which you saw on the very early map, and to take it into that area, which is our most rural, most isolated community, and the one that is suffering most from an exodus of healthcare workers, to say, how do we have a conversation about health and social care needs in the Fermanagh area, which would improve the outcomes for people living in rural Fermanagh. I'm going to stop sharing if that's okay.
Okay, Kate, and Ivan also, he has to he had to leave us, but great, I think. And on the one hand, you have a sharp analysis of the problems and the challenges in healthcare and mental care. But also, I think that's very interesting. This toolkit gives you an instrument to open up the dialogue about solutions. And I think that is great to go further on that. I think we can discuss this a little bit in the breakout groups later, because I would like, also because of the time, go to Karen Kay on our next speaker, because she will come up with one of the issues, and that is what was in your presentation, Kate, is that informal carers have to take over a lot of more of these challenges, and that's right. The project where Karen works on with in a Horizon project is called WellCare. My own organization, which you see the logo in, is an organization for voluntary care initiatives, and we work closely together with WellCare. So I give the floor to Karen from the University of Amsterdam. She's a postdoc researcher and very much involved in this WellCare project. Karen, the floor is yours.
Yes, many thanks for the introduction, Ben. And I wanted to say that one of the colleagues from our project, Gabrielle, is also here today. So great to see you. Let me share my screen. All right. I somehow get a notification screen sharing has stopped because it has stopped, but that's weird.
There you are again. Yeah. Oh, if you opened it up.
Yeah.
That was the problem with Kate also, I think, when she get to the broad mode, then
Yeah.
then it okay.
I restart PowerPoint. Hopefully it worked. And let's see. No, I will just share my my main screen. So unfortunately, no presenter.
Oh, now you're right.
Now it's working. Well, that's a nice surprise.
Yeah.
All right. Ben already offered a bit of an introduction. My name is Karen Kay. I work as a researcher at the Vrije Universiteit Amsterdam, and I'm involved in the European Horizon Europe WellCare project. And before I start, I have to give a bit of a disclaimer. The WellCare project isn't necessarily about rural health and rural communities, but I do see some overlap with some of the stuff Kate presented. And we can make a nice link also to rural healthcare needs. And I will also spend some time discussing that during my presentation. So let's start with talking about what WellCare is about. Well, the slogan of our project is investing in the mental health and well-being of informal carers and long-term care workers through the identification, promotion, and evaluation of good practices across Europe. And well, it's an Horizon Europe project, so that basically means that numerous countries are involved. So in the Netherlands, VU Amsterdam is basically the research partner, but in each country we collaborate with a, let's see. Oh, I was looking at the comment section. But in each country, we collaborate with basically like an advocacy partner. And that can be an association representing informal carers, for instance. And in the Netherlands, we collaborate with Netherlands Cares for Each Other, which is also where Ben is involved in, I believe. In this project, the Netherlands is involved, but so is Germany, Italy, Slovenia, and Sweden. And what we do in this project is, focusing on the mental health and well-being of these two groups. And when we talk about long-term care workers, we basically mean qualified nurses, personal care workers, nursing assistants, who are typically employed by a long-term care provider. And if we look at some of the facts, some of the key issues, we have 6.3 million people working in long-term care. And many of the people there are nurses, personal care workers, and they are exposed to low wages, long working hours. They struggle having a healthy work-life balance. Workload is already heavy and is increasing. And of course, we also had the COVID pandemic, which still left its marks. And if we look at the mental health numbers, basically, if you compare these workers with the broader workforce in the EU, you see that 66% of the long-term care workers is struggling with mental health issues, whereas on average this is 43%. So it's a significantly higher number of long-term care workers struggling with such issues. Then if we look at the other group we focus on in the WellCare project, they are the informal carers, and we use the definition that they are persons who provide care to someone outside of a professional or formal framework. And if you think about informal carers, you may think about, for instance, a daughter looking after her mother who's in a nursing home or who still lives in a community. But in the WellCare project, we take quite of like a broader definition of informal care. So one of the things that I will discuss in a bit more detail shortly, but one of the trends we now see happening in the Netherlands is that there is more and more emphasis on community and citizen initiatives. So instead of having the regular informal care, such as someone's son or daughter looking after his or her mother or father, we also look at what's happening in neighborhoods, basically have neighbors looking after each other. We also look at volunteers. So we have quite a broad definition of informal carers in our project. That being said, also if we look at this group, we see that many of them suffer from burden, depression, and that many of them also have difficulties balancing care, work, and their private lives. So with both of these groups, we see that the mental health and well-being is under pressure and is becoming more and more under pressure. If you looked at much research today, but also what is happening in practice across Europe, you see that these two groups are often treated separately. So you have initiatives focusing on long-term care workers, and you have initiatives focusing on informal carers. And in a way, that's understandable, because if you look at what causes these groups to have lower levels of mental health and well-being, you see that the sources can be different. So for instance, informal carers, they struggle maintaining their care and their private life. Whereas for long-term care workers, for instance, also shift work is a significant issue affecting their well-being. So in a way, these sources are different. But also if you talk to long-term care workers and informal carers, one of the things that does come up when you ask about issues that affect their mental health and well-being, you will probably hear that they say that also the collaboration between them affects their mental health and well-being. So what we do in the WellCare project is, instead of looking at these groups as two different groups, we look at them together, and we focus on the development of care partnerships. And care partnerships is a bit of a nice word, but what we aim to achieve in this project is improve the collaboration between long-term care workers and informal carers. Because if you look at research into this, when this collaboration is running smoothly, you see the mental health and well-being of both groups improving. So for informal carers, for instance, it really helps if long-term care workers also look after them, ask how they are doing, and really consider them as partners in care. And the same can be said for long-term care workers. It would be really great if informal carers could take over some simple tasks from them that can already ease the workload for the long-term care workers. So in that sense, the mental health and well-being of both groups is connected. Then what do we do in the WellCare project? The last 2 years, our biggest project activity was basically the identification of good practices across Europe. So our Italian colleagues, and Gabrielle was one of the leaders of this project activity. We worked on this identification of good practices. So we did a large literature study, both scientific and in the gray literature, in which we identified almost 170 good practices that have a positive effect either on the mental health and well-being of both groups or on the development of care partnerships. Then in another project activity that we are currently working on as well, we basically use the insights that we derived from the literature study, and we start working with local stakeholders in all of the 5 countries. So that can be long-term care organizations, for instance, or municipalities that are willing to or want to improve this collaboration between formal and informal caregivers. And we closely collaborate with them by developing and also assist them in implementing these interventions. And these interventions are based on the good practices that we identified in the literature study. So instead of doing just research, we also play an active role in society by improving this care partnership between formal and informal caregivers. In addition to these 2 project activities, we also analyze policies and we provide recommendations. So we look into policies in each of the 5 countries, but also at the European level. So we look, for instance, are there policies designed in the specific countries that have a positive effect on the mental health of informal carers? For instance, do informal carers get some reimbursement? Or not? What about like the gender differences in terms of informal care? Do national organizations, do policymakers take that into consideration, and do they design policy for that? And based on this analysis, we also provide recommendations. And basically, at the core of all of these project activities are the so-called blended learning networks. So we actively collaborate with people from society, and they basically have an advisory role in our projects. So for instance, in the Netherlands, we collaborate with so-called citizen communities or members of these citizen communities. We have people from formal long-term care organizations. We have informal carers, and they advise us throughout the project. Again, context is key. I think Kate already offered quite a nice overview of what is happening in Ireland. And if you compare that to what is happening in some of the other countries where the WellCare project is taking place, you see different situations happening, and also different groups of long-term care workers and informal carers. So, for instance, in Italy, what is going on is that there are a lot of domestic family care workers. So these are typically women coming from the eastern parts of Europe, and they are hired by families to provide informal care or provide some sort of care services. I wouldn't say it's informal. I guess it's not formal either. But that, of course, can be problematic because there might be suppression taking place. Racism also happens, can also happen in these situations, and also basically the working conditions for these domestic family care workers is really under pressure. Then turning to the Netherlands, I was already mentioning it at the beginning when I also referred to Ben. What we have happening right now is that more and more emphasis is being placed in caring communities. So instead of having formal care organizations take over, you see that people start organizing care more and more in their own community, which is quite a nice initiative taking place. We also have a bit of a unique situation concerning volunteers who offer volunteer services for long-term care organizations. So we typically say that informal carers, being family members, they are allowed to do everything. So they can even perform basic nursing tasks. They can give injections. They can help the client shower. But with volunteers, it's different. So if a volunteer makes a mistake, then the care organization is responsible. So many care organizations are hesitant to collaborate with volunteers. Looking at Germany, you often see that informal care and formal care are separate from each other. And that's also because in Germany, the formal care services are quite overloaded. So people basically have to arrange care on their own. And informal carers can't really collaborate with formal care after all. In Sweden, municipalities are the main care providers, but again, there are significant differences between them. And like what is happening in Ireland, there also the rural part plays a huge role. And it's also creating these differences. So that's also the reason why in the WellCare project, we don't just develop general interventions. We really organize this locally such that it fits the organizations that we're working with, but also the context of the country. I was already mentioning it. One of the main things that we did in the WellCare project is identify a variety of good practices that have a positive effect on the mental health and well-being of formal and informal caregivers. So we did a large-scale scientific literature review last year, and we also searched the grey literature. And we searched for good practices that support mental health and well-being, and also the development of care partnerships. So practices that have a good effect on the collaboration between formal and informal caregivers. We have 170 good practices identified. And this year we made a top 40 out of this based on selection criteria we again discussed with our BLN members, so our Blended Learning Network members. And the selection criteria, for instance, refer to the available evidence, but also the emphasis on care partnerships. I was in contact with our project coordinator yesterday, and she informed me that we are allowed to share the report with the 40 good practices with you. I do have to stress, though, that this report may be a little bit technical, so it contains a lot of information about how we performed this literature review, and we are working on a more accessible version, but I'm happy to share the report with you, should you be willing to receive it. And I thought, well, let's share some of the good practices that we have identified. So the first one is from Pflegen und Leben. I think it doesn't come as a surprise that this one is from Germany. It's a low threshold psychological online counseling. Let me see. Counseling service for informal caregivers. And the target group in this case is Germany. And it provides personalized online support for individuals caring for family members in need of long-term care. And basically, it's a platform where people can meet and interact with specially trained psychologists. And it's funded by 4 German long-term care insurance funds. And basically, the goal is to reduce stress, anxiety, and depressive symptoms among caregivers, while also improving their self-efficacy. And what we saw was that this online counseling service really addressed the underutilization of support structures. So people, especially when they are in need of psychological help, like really struggling also with being an informal carer, they typically have difficulties like saying this to people. So you have this stigma in place. And this low threshold online counseling service really addressed that. It's also really helpful in terms of regional disparities, particularly in rural areas, because it's online. And it's also anonymous, confidential, and it's basically offered or accessible nationwide. So also in the more rural areas of Germany. Another example that we have is Rosetta. It's number 13 from the 40 identified good practices. And it's an electronic personalizable e-learning system designed to support informal carers of people with dementia across Europe. And what we commonly see when people become an informal carer, that they have like this huge need for information, that they want to be involved in the decision-making process concerning the care for their loved one, but that they don't always have all the information in place. And Rosetta is a way that supports them in this. So it addresses the educational and emotional support needs of informal carers. And it consists of various platforms addressing understanding dementia. So basically like a knowledge module, but there's also modules on stress management, coping with emotions, and how to access support services. And it was developed in 5 countries. And it was considered really user-friendly. Well, the final good practice that I want to discuss today, unfortunately, did not make the top 40. And I think that's a bit unfortunate, because it's a good practice from the Netherlands, and I think it's really promising. Also for members of a rural community. So I would still like to discuss the community circles with you today. So in Dutch, we call them voorzorgcirkels. And community circles are basically groups of 10 to 15 citizens who agree to support each other. And it's really organized locally, so in someone's neighborhoods. And the circles are there to offer day-to-day help. So that can basically be getting some help, getting you to the GP, someone driving you to the hospital. It can be having dinner together, drinking coffee together, so really addressing the social needs. And these community circles are basically led by 2 coordinators. And the role of these coordinators is to match supply and demand. So if you have a request, for instance, you want to have more social contact with the people in your neighborhood, you can reach out to the coordinator, and then the coordinator will match your request with someone. So how do these community circles work? Well, they are mainly, or in most cases, initiated by citizens, and sometimes nowadays also by municipalities or care organizations. Because these municipalities and care organizations see how successful these circles become. And you may worry a little bit about, are people like motivated to contribute to these community circles? Well, the idea behind these circles is that they are based on reciprocity and intrinsic motivation. So right now you may deliver a bit more care, and then in the long run, you may be the one who gets the care from the other people when you become older. So it's voluntary, but with a serious commitment. And that's also the role of the coordinators, to make sure that people who are a member of such a circle, deliver like a serious contribution. I was already discussing that emphasis is placed on offering day-to-day help, but circles, especially those who have been in place for a couple of years, they can discuss whether medical support is also delivered. So in some circles, for instance, neighbors support each other, like with eye drops, putting on compression stockings. So it can also be a bit more like professional care that is delivered by these community circles. Then what are the benefits of these community circles? Well, the biggest benefit is that it normalizes asking for help when needed. So you may be in need of help, and people really struggle with saying to others that they are in need of this help. And these community circles basically normalize this. It also creates a sense of care security. I was already saying that, well, now that you're, for instance, when you're 65 or 70 years old, you may take on a large role in such a community circle. And then when you grow older, you may become the one who gets the help a bit more. So it's basically this reciprocity taking place. It also strengthens social connections within communities. It may reduce the pressure on formal care services because in some cases, these community circles take over from formal care providers, at least some tasks, of course. And another big benefit is that these community circles enable people to live independently for longer. And people really want to live in their own neighborhoods. Ivan was already discussing that during his presentation. And the community circles are a great initiative supporting this. So these were just 3 of the identified good practices. I was already mentioning that we have identified 170, and 40 of these are reported in the report that we published. So get in touch should you be willing to also look into the other identified good practices. We're happy to share it with you.
Okay.
And that was it from my side. Thank you very much for your attention. And should you have any questions, feel free to reach out.
Thanks very much, Kate. There was already one question from Tom. Are these people that help these community circles, are they paid staff or not?
Well, basically the coordinators, that is just like a volunteering role.
Yeah.
But for instance, we have Netherlands Cares for Each Other. That's I wouldn't say that is like a formal organization, but they offer all sorts of support to these community circles.
Yeah.
So they help with setting this whole circle up, get it up and running. But they can also offer a bit more like long-term support. So if you have issues taking place in your community circle, you can turn to Netherlands Cares for Each Other.
Okay, so Tom, basically those local coordinators are volunteers also.
Yeah.
We are running a bit out of time, but I think it is always important in this web events. We could do 2 things. Go into questions, but I think it would be nice to go also have, for instance, 20 minutes or 25 minutes to go into breakout rooms, so everyone can share his own experiences. And Jessica, Karen, and we will be the moderators in these breakout rooms. And Louise will send us now in the breakout rooms. And then we will come back and we can wrap up a little bit. But I think it's nice to also share your experiences in your own countries. These two questions we already had on the table from Kate. The pressure on the healthcare and mental health care on the one hand, and the other hand, is it possible to have the community and voluntary sector to solve of this some kind of these problems, and what are the challenges for that? Louise, can we go into the breakout rooms?
Yeah, I'm just setting them up now, so just be a few minutes.
So when we are in the breakout rooms, we will get a quick idea of 2 things. What is working well in your own country? Do you have experiences? And the other is what is the impact to the fact that a lot of pressure is now on the voluntary sector?
Okay, I'll send you to the rooms now. This should be open. Okay.
Okay.
If you just hit join.
Not all of us. I hope, like in our always, although small group, we had a good discussions. Just a quick sum up of that. On the one hand, there is a very much recognition for what Kate, the data that Kate brought forward. There is a real big challenge to keep up a adequate system of healthcare in the rural areas. That is really everywhere is that. So the one hand, and when I come to a very quick conclusion, what we should do, and perhaps every one of us has to do in that, is to raise the voice of the rural areas, that this inequity between urban and rural systems of healthcare is not acceptable. And we should also, I think Kate or Corinne also mentioned an important issue in that, is that we should also have the right data. For instance, this was a very special example of the mortality rates in rural areas are lower as in urban areas, but that is a very blurred data. So there's a lot to do on the one hand to raise the voice of the rural areas concerning the healthcare system, and on the other hand, I think there are chances and possibilities to strengthen the informal care, and that there is, I would mention also a nice, a good example from Northern Ireland, where informal care is some kind of a protected function. Perhaps that could be also introduced in other countries. That is too quick, but I go to Jessica. What was the outcome of your discussion?
So we had a discussion about our overall reflections from the presentation and then the 2 questions, Ben. And we started off by having a discussion around the kind of accessibility to health and care services in rural areas, both kind of physically in terms of distances, but also digitally as well. And, you know, there was this real line, wasn't there, between the evidence and the data that Kate presented versus my colleague in Flanders, who, you know, you could get to a hospital within 15 minutes. So there's a real disconnect there. We had a really rich discussion about actually what is the role of the voluntary sector here. So is it about adding value to what already happens? Is it about replacing parts of the health and care systems? Or is it about saving money to the public purse? Or is it about something else? And so that led us to have quite a wide-ranging discussion with some examples of, you know, people who are presenting to health and care services, but it may not be a clinical condition, and where the voluntary sector is kind of picking up that support, and how that can be part of a kind of multidisciplinary team approach. So we thought that was all quite important. We do think that health and care systems do need to do some reorganisation, so they think more locally, more about community, more about neighbourhoods, more about the voluntary sector. But we also had a discussion around volunteering, because there's often this view that some countries volunteering is more built into the culture than others. But actually, you know, who is volunteering, and what are we expecting from our kind of volunteers there? We also had a discussion which was slightly different than some of the other presentations, which was about, you know, how can we take some of the pressure off the clinicians, and particularly where they're spending time not just with patients who don't have a clinical need, for whom perhaps the voluntary sector could support them, but also the amount of paperwork and form filling they do around helping people apply for things like mobility support to perhaps get a car, or stuff around whether or not they're fit for work and employability, or kind of, you know, whether or not they need certain documents for an insurance company. And that led us to our final point, that actually, you know, if this is about helping keep people well and reducing their need to present and access and use health and care services, thinking more imaginatively about insurance companies is quite important. And then finally, we didn't have time in the session today, but there's lots of interest in digital and artificial intelligence, and what are the opportunities around technology and making sure that rural areas and rural residents are not forgotten in all of that. So I'll just check if anybody in my group, if I've missed anything. No? Okay.
Okay, then
Very well.
Thanks. Oh, great. Karen, what was in your discussion?
Yeah, before discussing that, I want to respond to Jessica's comment about artificial intelligence. And I think that holds a lot of promise also for rural communities. But I think the main thing that you should always be aware of is that it's always like organized with the end users. And we often see that artificial intelligence is now basically the holy grail in healthcare, the solution to all problems. And very often it costs a lot of money, of course, to design it. And then it doesn't really fit the needs. So I wanted to respond to that. Well, some of the things that came up in our group is, again, the differences in how rural is rural. So we had an example from Lithuania where rural basically means living in a small community of like 10 people. So of course it's important to take this context into account. We also, one of the things that came up were also the more like structural issues that affect, that have an effect. So Becky from Scotland was also referring to my presentation about the interventions or the good practices that I discussed. The problem with that, of course, is that it again lays a lot of responsibility with the individual. So you're struggling with your mental health, follow this course and it will improve. But you always have like these structural issues in place. And during our discussion, for instance, money was discussed. So rural areas really struggle with the financial components. But also a lack of healthcare professionals willing to work in these areas, but also like in general. And in terms of like volunteering, again, there are a lot of differences between the countries. So very often it's organized also by the Red Cross. So we had examples from Lithuania and Iceland. Where they have this like really volunteering group also in the community offering help. And I'm thinking, are there any points I missed? I'm looking at members of my group. Do you have anything to add? I see people nodding. So I think these were the main, main points.
Great. So thanks. I think we had a rich discussion, and I think Kate, you really made us, and also Karen, you really made us think about a very big challenge for rural areas. And on the one hand, I think we have in these introductions, also from Ivan, a more clearer view on the challenges which are there for the rural areas. And I think these challenges will not go away without that, because, for instance, the amount of elderly people will grow until 2040. So the pressure on rural health will be there for the upcoming years, and it is up to us to do, I think, two things. On the one hand, raise the voice for rural areas that we deserve a fair share of health care providence and all that. So we should really be eager to put this right on the right way on the agenda. That's, I think, a national problem, but perhaps also a question for ERCA. And on the other hand, it is also good to hear how we can share tools like this toolkit with a very interesting and other best practices, like Karen mentioned, but also we learned from others to find the solutions that are possible already now. And I think one of them is also this informal care and more preventive, being preventive or digital. There are also solutions, and it is also good to share these things. So I think it's not the last discussion we will have on this issue, but it was great to see each other. I thank very much to the speakers. It was really inspiring to share all this, And perhaps Tom, a last word from you, or?
Well, Ben, well, just to thank you initially for organising this event and making sure that we have very good speakers as we've had today. So very, very briefly, just to thank everybody for participating. I think it's important that the Horizon research work that is being undertaken, that the findings will be shared not just within the EU, but outside the EU as well, because there are plenty of similarities in that work and in the needs of our rural communities. I think we still have, as somebody has said today, an awful lot of campaigning still to do on rural proofing and devising specific rural health solutions. We've heard some of them today, but how we turn what we've heard into campaigns directly with local and central government, and more centrally with the European Commission. I think it's important that health issues are raised at all these levels, because they will affect the quality and the attractiveness of our rural areas. We've talked today about the lack of being able to attract GPs into our communities. Well, we have to make certain that, for one reason, the health provision that they would wish their families to grow up in is at least compatible, if slightly different in the way it's delivered, from their urban colleagues. So all I would say is thank you all indeed for participating today. And Ben, have you got any more sessions in the pipeline for next year?
Yes, it was interesting that someone mentioned transport. We will also have a web event on transport together with our Irish colleagues, and the last Friday of the next month, we will also have a presentation from Acre about their work. So that there's a lot of, so keep your agenda open for every last Friday of the month, because there will be an ERCA Cafe or a web event on one of the important issues that we all struggle with, I think. And of course, Louise, we will share our the PowerPoints and a short, I think, report on this. So everything will come back to you, and that would be everything, I think.
Thank you.
So thanks very much, and have a nice weekend.
Thank you. Bye-bye.
Thank you.
Bye. Thanks, everybody.
It was very interesting.
Bye-bye.
Bye.